Hello and good day, everyone, and very welcome to this Burden EU webinar on quantifying COVID-19 disease burden. My name is Brecht de Vleeschouwer, and I'm chair of the Cost Action Burden EU, the European Burden of Disease Network, and together with the Uncover Network, led by José Peñalvo, we are very happy to host this very interesting workshop. So the idea of the workshop is to give you some initial insights in the COVID-19 disease burden, but especially to unravel some of the key assumptions and decisions that need to be made when quantifying COVID-19 disease burden. We will be having 3 presentations by the speakers that you can see here on the screen, and that will be introduced later on. So as mentioned, the webinar is co-organized by the Cost Action European Burden of Disease Network and the Uncover Network. So our European Burden of Disease Network is a cost action that aims to integrate and strengthen capacity and burden of disease assessment across Europe and beyond. So in this sense, we are very happy to be able to use COVID as a case study to help introduce some of the key concepts in burden of disease assessment. If you want to learn more about our cost action, feel free to have a look at our website. The webinar is co-hosted together with the Uncover Network, so I would like to ask José to give us some introduction on the Uncover Network.
Sorry, I was muted. I was just saying good morning to everybody, and thank you, Brecht, for the invitation to host with you this webinar. My name is José Peñalvo, and I work at the Institute of Tropical Medicine in Antwerp. And today I'm representing the Uncover network, in which members of the EU Burden are also participating very actively. Uncover is a new project that has been awarded.
Has joined the meeting.
Has been awarded recently by the AIDS 2020 program, and it deals with a network of partners that are capable of harvesting real-world data, mostly coming from hospitals.
A participant has left the meeting.
And other health systems across Europe and internationally, providing care to COVID patients. We are representing 18 countries, 14 in the EU and 4 non-European countries, 29 partners, many epidemiologists and also physicians.
A participant has joined the meeting.
And providing big data sets, one pool, of course, with many.
A participant has left the meeting.
Variables to study. So our goals is to standardize, develop models for quantifying different aspects of COVID related aspects, provide a platform for pool analysis and hopefully follow up of these patients. Like I said, we just started, so we don't even have a web page yet, but please feel free to contact me or Brecht for any questions. Thank you so much.
Okay, thanks a lot, José, for this introduction. So a few notes on the webinar. So we would like to ask all of you to mute yourself and switch off your videos during the presentations so that we can keep a focus on the presenters. I'll also try to disable the option that we hear that people are joining and leaving the meeting. If you would have any questions during the presentations, please feel free to use the chat box to type in your questions. After each presentation, Sarah Pires, who is also joining us and who is the lead of the infectious disease working group within our cost action, she will help us to moderate the Q&A session. Okay, so let's get started. So we will have 3 very interesting presentations. First of all, Grant Wyper from Public Health Scotland will give us an overview of how Burden EU can help to develop resources on COVID-19 disease burden. And then we will have two inspiring examples from real life. We will have Dr. Giske Lagerweij from the Netherlands National Institute for Public Health and the Environment, who will guide us through the decisions and assumptions that they have made in the Netherlands to quantify COVID-19 disease burden in their country. And finally, we will have Professor Dr. Minwo Jo from Korea University of Ulsan, who will present us the COVID-19 disease burden estimates for his country. And this was in fact the first published set of estimates of DALYS for COVID-19. So with that, I want to thank you all for being here. And then I would like to give the floor to Grant to guide us through the Burden EU resources and support in quantifying COVID-19 disease burden. Grant.
Okay, thanks, Brecht. I'll just share the presentation just now.
Perfect.
Okay, thanks. Thanks, Brecht. Thanks to Brecht and Josie for inviting me to this webinar to present. I'm a Public Health Intelligence Advisor from Public Health Scotland, and I've been very fortunate to work alongside others in the Burden EU network to plan and undertake activities related to COVID-19 burden of disease assessment. Today I'll give an overview of these activities and the progress that has been made so far. So to start off, it's worth quantifying what we mean when we talk about burden of disease assessment. This may mean different things to different people. We are interested in the concept of disability adjusted life years, known in shorthand as DALYS, which many of you may already be familiar with. DALYS are a summary measure of population health that incorporate both the impact of morbidity and mortality. For morbidity, this is made by taking into account both the frequency and severity of disease and injury to estimate years lived by disability, or known as YLD in shorthand. And for mortality, years of life lost, or YLL, are estimated by taking into account the frequency of death and the age upon which it occurs. DALYs are estimated by adding these YLD and YLL estimates together, and this gives us an estimate of the full healthy years lost due to living with and dying from causes of disease and injury. These are helpful because they allow comparisons to be made across both causes of morbidity and mortality, things which mortality or just morbidity-based indicators don't allow us to do. And this is very useful because DALYs can then therefore inform debate around informing public health priorities across all causes. Finally, it's worth noting that DALYs are an indicator of the health gap between the current health status of a location compared to a counterfactual scenario of living free of disease and injury. So when thinking about how COVID-19 relates to burden of disease assessment, the key questions which have been under consideration in our network have been to try and understand how existing burden of disease assessments can be useful in the COVID-19 times. And secondly, as burden of disease assessments are comprehensive across causes of disease and injury, we've naturally been looking into developing methods to assess DALYs due to COVID-19. Our network itself is structured into 5 working groups, which are defined by 3 vertical pillars of non-communicable diseases and injuries. The second working group is communicable diseases. The third working group is risk factors. The 2 horizontal groups of methodology and knowledge translation underpin the work of working groups 1 to 3, giving it a transversal structure. This structure has been useful to think about how burden of disease assessment can be informative for COVID-19, especially when organising our activities. When thinking about population vulnerability to COVID-19, existing burden of disease assessment for non-communicable disease and injury can be very informative. Secondly, the direct impact of COVID-19 can be considered under Working Group 2 of communicable diseases. Finally, when thinking about the indirect impact of COVID-19 health harms for which COVID-19 would be a risk factor, Working Group 3 seems like it could be a natural home. The important thing is, underpinning all of these is the importance of methodological rigour and good and effective knowledge translation. So our first activity took place early in the pandemic. Burden of disease assessments of populations are very useful to show how healthy or vulnerable population health is, and in the COVID-19 context, this is no different. Evidence had emerged linking specific health conditions and increasing age with severe outcomes from COVID-19 infection. Existing estimates could therefore be used to establish a baseline for pre-COVID-19 population health. Within our Burden EU network, a group of around 20 people convened to establish the relevance of existing burden of disease estimates in estimating population level vulnerability to COVID-19. At that time, many countries had started to develop specific lists of health conditions and risk factors that identified those that were most vulnerable to severe outcomes, largely for population shielding purposes. We used a list based on guidance from the UK government, and we cross-referenced this with the cause list from the Global Burden of Disease study to summarise population level ill health using YLD estimates. And these were also paired with estimates on the rate of elderly population, given that age was a known risk factor. The aim of this activity was to show how rapid burden of disease assessments could be performed in the COVID-19 context and how population level health assessments could be beneficial. These could be more usefully developed to incorporate within country subnational assessments too. For anyone interested in further information, this paper has now been published in the Archives of Public Health journal. So once we had made the first assessment of vulnerability to COVID-19, we started working on establishing COVID-19 as a cause in burden of disease studies. And this is important for many reasons, if not only for the fact that COVID-19 is among the leading cause of death in most countries. Some attempts emerged to try and treat COVID-19 differently at the time through release of both mis- and disinformation. And there were suggestions that those that were dying of COVID-19 were going to die soon anyway. And to illustrate this, some people had used life expectancy at birth wrongly to frame the remaining life years for elderly patients. However, as we know, by living to say 80, you've avoided the mortality hazards and you're expected to live much longer, over a decade more. So some of these messages were widely shared, but they've now been debunked, which underscore the importance of both good and transparent methodology and effective knowledge translation. By establishing COVID-19 as a cause, it allows standardised comparisons with other causes, and it's a start to try and segment both the direct and indirect harms of COVID. Another advantage in doing this is that the burden of disease framework, the methods have been established for over 25 years now, and they therefore can't be accused of just trying to fit a narrative. And as we embarked upon this work, some preprint papers and published papers on burden of disease assessment of COVID-19 started to become available. And as they became available, we started to log these on our Burden EU website. We've included the link here for anyone that's interested. So we've been collecting papers based on DALY methods or those which are applied COVID-19 DALY related assessments. We then started to tackle the methods by focusing on the YLL, and this was topical as it was important to try and dispel myths over YLL calculations, and in particular to underscore the importance of transparency and documentation of method choices. This is because YLL assessments are very sensitive to change. For example, you can get very different results depending on whether aspirational life tables are used compared to national life expectancies in the calculations. So we published a commentary in the International Journal of Public Health to try and talk about some of these issues and to try and advocate for methodological transparency. For example, life expectancies can always be subject to some form of criticism, and the main opposition of using aspirational standards usually cite that life expectancy is too variable between countries. However, many within country life expectancies or national life expectancies are highly variable too, but it's less common or seen as being ethically acceptable to have stratified subnational approaches. And in addition, COVID-19 presents us with a possible paradox in that this year the likely increased mortality will result in reduced life expectancies, which in turn could actually result in lower YLL as the deemed value of life appears to be decreased in YLL calculations. So from this work, we've some recommendations. Firstly, using a standard life table such as the Global Burden of Diseases or the WHO's can avoid the paradox of YLL decreasing when deaths are increased. And similarly, there are ethical advantages in that the value of life is the same both within and across countries of the world. There's also a comparative advantage that YLL and therefore DALY estimates can be more easily compared due to using similar methods. And this especially seems to be an important point for COVID-19, given it's in a global pandemic. A final point to make is that many countries or many researchers have sought to adjust the YLL since COVID-19 has occurred in people that have been perceived to have a higher risk of death than average. We would advise that any adjustments would be selective, as they're not routinely applied for other causes of disease, such as Alzheimer's. The majority of people that die do so because they do have a higher risk of death than average anyway. And if this is carried out, then all-cause YLL estimates in particular would suffer because it would result in a loss of focus of the factors and environments responsible for bringing about these increased mortality risks in the first place. So within the Burden EU network, many members were starting to think about calculating country-specific DALYs. Looking to build upon our YLL recommendations, a group convened to discuss and establish health states and possible data inputs. This work centred around a disease model for estimating YLD and YLL and therefore DALYs, but we also found it important to discuss the issues of uncertainty related to data inputs, given that data availability and quality is likely to vary substantially by country. So we've developed a consensus model, which was made available as a preprint towards the end of October. This is the main figure of that preprint. It's an outcome tree summarising our consensus model and approach to estimating DALYs due to COVID-19. For YLD, we considered stratified severities ranging from community cases to hospitalised cases requiring intensive care. And we also allowed for the estimation of post-acute consequences such as fatigue. For now, it doesn't include any other long COVID health states, but as evidence and transition probabilities and durations emerge, then we would look to update this outcome tree to reflect that. Our most recent COVID-19 activity has been to develop a protocol for estimation. This has been led by Dr. Sarah Pires and has now been published on the Burden EU website. Where this differs from the consensus model paper is that there's a wider discussion on the data requirements for undertaking burden of disease studies, and it includes some information from case studies that countries that have already performed COVID-19 assessments, such as the Korea study. Additionally, it talks more about the general requirements about undertaking burden of disease studies, and in particular to try and give some pointers on how results and findings can be communicated in an effective manner. We would encourage anyone that was wishing to undertake a COVID-19 country-specific assessment, or who want to share experiences of doing so, to email the network, and we can look to include it in the protocol. Finally, the ongoing and future activities within the network include continuing to support and encourage efforts to integrate COVID-19 into burden of disease assessments. What has become clear during the pandemic is methodological rigour is very important, and public health practitioners have an important role to be able to comment on issues of public health impact. For now, I've said before that we've included post-acute consequences into our outcome tree, although data inputs are relatively sparse at the moment when making population level inferences. As more information on COVID-19 and potential health states emerge, then we look to update this non-fatal outcomes tree via the protocol. And an area which we've not yet carried out much work in is assessing quantitatively the indirect harm from COVID-19. Some opportunities may emerge through things like foresight studies by comparing deviations between actual and forecasted DALYs. Additionally, there may be some important indirect implications for aspects of burden of disease studies, such as disease severity, which would occur through the restricted access to vital services via national lockdowns, and this may have large implications for the estimation of YLD in the future. So many thanks for listening. I hope that this summary has been informative for you in understanding our activities, how they've been adapted to include COVID-19. I believe these slides will be made available via the Burden EU website, so I've included some links for further information on some of the activities which I've discussed, which I hope you find helpful. Thank you.
Okay, great. Thanks a lot, Grant. So I see we have a few questions already in the chat.
Yeah, I'm happy to read
Sarah.
it for Grant. Yeah, we have a couple of questions. They are related, both of them are related to disability weights. So the first question for you, are the same disability weights for calculating DALYs applied across different European countries?
Okay, thanks for the question. So yes, in our consensus model, we haven't actually performed any country-specific assessments across Europe. So they're really, the basis of the model is for researchers to calculate their own DALYs, but the disability weights which were used were similar, well, the same ones which are used for lower respiratory infections in the global burden of disease study. But to try and incorporate the cases which we've been seeing from intensive care, we also included the intensive care disability weight from the European disability weight study.
Yeah, and then the second question is actually, I believe you answered it, where did disability weights come from? So you just answered that question, and you can correct me if I'm wrong, but these information and references are also in the preprint publication you mentioned, right?
Yes, there's further information in the preprint and the protocol too. That's good to answer them up front.
Okay, great. So if there would be any further questions, you're of course also very welcome to contact Grant or us directly. But I suggest we continue with our program. So then after this theoretical introduction of how COVID DALYs could be calculated, I suggest we have a look at the decisions that a specific country has made, because indeed these decisions have to be country specific, because the assessments have to be based on the availability of the data. So I am now asking Giske to take the floor and to share your screen to start the presentation. Thank you.
Yes, thank you. I'm still busy trying to, oh, yeah, I found it. Okay, well, thank you, Brecht, and thank you, Grant, of course, for your nice talks and maybe a little introduction. Well, my name is Giske, and I'm gonna tell you something about the decisions and the discussions and all the talks I've had with colleagues in the process of assessing the burden of COVID-19 in the Netherlands. So first, I will tell you something about how things are organized in the Netherlands. For example, on the data we had on the COVID-19 cases. I tell you something about the disease tree we used for the calculations, and then something about the two parts of the burden, so the YLD and the YL estimates. So to start with, we got the number of positive tested and died patients via a system at the RVM. So all the people that were tested were notified and were saved in the database. We also got a national intensive care evaluation organization. These people are registering the ICU beds that are occupied, so that the data is quietly complete. In the beginning of the pandemic, we only had the ICU data, but later on also the number of beds that were occupied at normal departments of the hospital. So other people that were hospitalized that were not on the ICU were registered and notified via this system. And then we also have data from causes of death that were registered by the statistics of the Netherlands. So a little bit different than the disease tree that Grant showed, we used the clinical pathway because of the data that we had. So we really had data on mild cases, moderate cases, and ICU cases. So we decided to say, okay, we have a number of mild cases, and a proportion of that will go to the moderate health outcome, and a proportion of that will be hospitalized at the ICU. So we included all those phases separately. So we have included also a mild phase for the moderate people, and again also for the dead people and for the severe people. So that's one of the choices that we made. So then furthermore on the estimations on the YLD, a large part of estimation, the YLD, is of course the number of cases that you have. For the mild cases, we had the test capacity in the Netherlands, and especially for the mild cases, was not very big in the beginning. So our number of mild cases will be very underestimated because, well, most people were not tested, especially not if you're just were sick and were at home and maybe called the GP, but that's it. In the beginning, only healthcare workers or people in the high-risk categories were tested. Later on in the period, the test capacity increased, so we could test more people. So then the numbers of mild cases will be more accurate than the reality of people that were sick at home. For the hospital cases, like I said in the beginning, we used the number of notifications that were just at the RVM. Yeah. But a lot of follow-up was missing. So people were notified or registered because they were tested positive. But if they were then hospitalized a few days later, that information is not is not available because of the workload, because of a lot of reasons. So we know that people may be a mild case, but maybe not hospitalized. And the same for the fatal cases. A lot of people that died were not tested because of reality, because of of course, ook the test capacity. And for the reality, I mean that if you're sick at a nursery home, luckily you're not, well, you were not, maybe not tested immediately because, yeah, well, you're a bit older. And so, yeah, well, many people died just without a test. Then there is the part on the comorbidity. By that I mean that people that were sick were often already got an underlying disease, so maybe heart disease or another disease. So that has an effect on your YLD, because we also discussed it with the group, but people that were already sick maybe have a severer sick period, so maybe you should correct for the underlying diseases of these people. And then there is also the long-term complications. So there is not very much evidence available yet, but you can think about mental problems or post-intensive care problems and complications. So what did we do here in the Netherlands? For the mild cases, we tried to estimate the underestimation in the first period. So and by the first period, I mean the first months of the pandemic here. So we used the months of March until June. What you could do is calculate, for example, the ratio of mild cases versus hospitalized cases. For us, the data in the later months, so July, August, and September, were more accurate and more complete. So you could then extrapolate to the first months and say something about the under-assertment that you have in your mild cases. Then for the hospital cases, we had the National Intensive Care Evaluation Organization that had a very complete register about the ICU beds that were occupied, and later on they also knew how many beds there on the other departments of the hospital were occupied. So that, combining with the data that we had at the RVM, we could estimate and factor to correct for the underestimation in the hospitalized cases. And then for the fatal cases, we decided to use excess mortality models. We also use them for other infectious diseases like influenza. So for that, we could have estimate what the more correct number of fatal cases would be in that first wave of COVID-19. For the comorbidity, we decided, well, we investigated it, what kind of effect it would be having on the YOD estimates, but at the end we didn't incorporate it because the data was not very complete, and we didn't really know how to make it more accurate. And furthermore, maybe more important is that for other infectious diseases and the estimates on the burden, we don't do anything with morbidity. So we decided to do it as well, not for the COVID-19 estimates. And for the long-term complications, well, that will be included in the future, but I am not going to show you anything. We didn't do it yet. So this is a first result on the numbers of cases that we had in the Netherlands. So for the mild cases, we had about 34,000 people, and the estimated YLD. And the YLD are estimated with the parameters that Grant showed. So the disability weights for the duration, we used the data that were available, and also showed in the paper of Grant. We did some little adjustment because we had later on we had some data on how many days people were staying in the hospital, so we decided to use that data as well. And like I said, we decided to say that people that were that died due to COVID-19, they also got a mild phase. So that's why the fatal cases also have a YLD estimate. And then we estimated some correction factors for the underestimation. So for the mild cases, we estimated that for each case we had in the data that there are 9 other cases were at home, but well, we didn't know that, so we had a factor of 10. For the hospital, the data was more complete, just the hospital cases that were not on the ICU. The factor between that is around 1.17, and for the ICU cases, the data was complete. And for the fatal cases, we used the excess mortality models, and at the end, we estimated that almost 10,000 people died due to COVID-19 in that first period of 2020. Then something on the estimation of the YOL. Like I said already before, due to test capacity and of course just reality, people died just before they were tested or the possibility of being tested. Another important thing, and Grant also mentioned it, is the life expectancy that you use. And in our cases also, especially for the 85 and years older cases, there was a large amount of cases that died and were 85 or older. At the end, we used the life expectancy tables from the Netherlands. I will show you later what the other tables are. And another thing is the same for the non-fatal cases, is that people, COVID-19 patients, they may have been already sick, they have underlying diseases. So the question is, of course, are all cases due to COVID-19? That problem is also, of course, present at other diseases, but maybe COVID-19 is a more difficult one, or there are more reasons that people really died due to COVID-19, unless if you're talking about influenza, of course. So yeah, well, should you correct for severity? Should you adjust your life expectancy? That kind of stuff. Well, already a little bit mentioned, we used excess mortality models, and also the Statistics Netherlands. They, like I said, they register the number of deaths together with the cause of death. The numbers are made available a little bit more earlier in the year. Normally you get the numbers at the end, maybe the next year, but now the numbers of people that died in the first months of 2020 are already available. So we use them to make a more realistic burden of disease estimate. Well, for the topic of life expectancy, well, for comparability with other infectious diseases, well, for the other infectious diseases and the burden estimate, we always use the global burden of disease life expectancy tables. But yeah, well, you can also discuss if you maybe should use country specific, but then it's not comparable with other diseases that. Okay. Okay. For the people that died, the number of people that were notified at the RVM were about 6,000 people with the YOL, and then with the excess mortality models, we estimated that about almost 10,000 people died with the correction for the YOL then. And then, like I said, for the life expectancy table, in the first two columns on the left side, I present the life expectancy numbers that I use for the COVID-19 burden. The reason that I used them is because we had, especially for the excess mortality rates, the age groups were fixed, so we could not adjust them. So we had groups of 0 to 4 years, and then 4 to 14, and then 25 to 34, etc. So that's why I decided to use these life expectancy numbers to estimate the burden. And for comparison, I present the numbers of the global burden of disease life expectancy tables, and like you can see, they're a little bit different. So the estimation would also be different if you use the other life expectancy table. Yeah, then something about the underlying diseases. Like I said, from the Statistics Netherlands, we got the first results, and that number is almost the same as our excess mortality model. So around 10,000 people died with COVID-19 as a cause in the first months of, well, the first months of the pandemic, as I mentioned before. So that's March until June. And for the correction for severity, we didn't do anything, mainly because of the comparability with other infectious diseases. Oh, yeah. And then to show you something of the influence if you're using 5 years or 10 years age groups. Like I said, we for the excess mortality models, we had to use those fixed 10-year groups. So our main results for the first report is based on that. But you could also use some other proportions of the cases. So I present both types of age groups. So these are the 5-year groups, and then the total burden on the notified cases is about 57,000 DALYS. But if you're using the 10-year age groups, you got a slightly different estimate. And so I would like to show you that, because I think it's very well. It's important that you choose, of course, but also to that you consider it in a good way, that what kind of method you use, and that you are, of course, transparent about it, because it can give different numbers of the burden estimate. Another thing that I wanted to show you is that it's a large the ratio between the YLD and the YL is very large, because the main almost 99% of the total burden is caused by the YLL. So on the left axis here, you see the DALYS for the YLL, and on the right axis, you see the DALYS for the YLD. So it's a huge proportion that is of the burden that's caused by the early death of people. So to summary, it's important now, to be at least transparent about the method that you use for estimating your burden, of course. So if you're gonna include your mild phase to the other phases and the other cases, yes or no. Will you include, of course, the long-term complications? And then for the YLD estimates, are you gonna correct or adjust for comorbidity of the patients that you have? Are you gonna correct for the underestimation, and in which way? And then for the YOL, of course, it's important to say something and be transparent about, well, what is your number of cases about? Is it people that died with COVID or due to COVID? What choice have you made for your life expectancy table? And is it on the global burden, or is it for your country specific? And are you going to correct for your underlying diseases or maybe age? So that was my presentation and my talk.
Thank you so much, Giske. I think we're a bit short on time, but I would like to share that there's some discussions going on the chat room. So one question about seroprevalence, about the utility of seroprevalence to correct for underreporting, and then Scott McDonald, your colleague, also started answering this question.
No. Scott is my helper.
Yeah. So I think it might be a good idea that we move on to the next presentation. What do you say, Brecht? Thanks so much for the presentation.
Yeah, maybe time for one question. So there was, I think, an important question by Neville at some point.
About the mortality, and Neville says
Yes.
question has been answered, but I can read it.
And about the attribution, actually. Yeah.
Well, the attribution pending. I think you touched a bit on it, Giske, if I may. But obviously, as you are aware, many of us facing questions from, let's say, anti-COVID lobbies or COVID denier lobbies as to how much of the burden of disease is, would have happened anyway because of the chronic conditions that many of these comorbid patients would have had anyway. Do you feel that the methodology you're using in the Netherlands addresses this satisfactorily, or maybe there's more work to be done?
I think that I feel something for the fact to adjust a little. Yeah, well, not maybe everything, but to do something with the chronic diseases that these patients have. Maybe not to say that you should really change your methodology and really incorporate and adjust for that chronic disease, but maybe as a more scenario, so to show your results without taking into account your chronic diseases that these patients have, but also to show what kind of effect it would have if you would adjust for it. So maybe as a two scenario basis.
Yeah, maybe Henk also wants to add to that.
Yes, maybe I had yesterday the Dutch Demography Day, and I was in a session with a presentation from Rotterdam University, and they made estimates how many years of life lost there are per case, and they adjusted for the underlying diseases, but also adjusted for the people living in elderly houses that have a lower life expectancy. And even with the highest adjustment, still there was 6.5 years more or less lost per case. And in let's say the maximum, it was about 9 to 10 years lost. So still, I would say considerable amount level.
Yeah, and to add to that, so I think it's also important to reflect a bit on the definition of what a DALY really is. So in theory, DALYs try to quantify the healthy life years lost compared to an ideal scenario where there is no disease in the world. And so we want to compare how much healthy life years are lost compared to a world without disease. And this allows us to put every different disease at the same level. But what some people try to ask is to quantify the healthy life years lost due to COVID compared to a world without COVID. But this is a totally different concept, and it's very important to distinguish between these two counterfactual scenarios and to make clear that when we talk about DALYs in the burden of disease framework, we are always comparing to a world without disease and not to a world without the specific disease. So this might help in these discussions.
Yes, I think that helps a lot, but still there are many people, and especially if you look at health economists, that are using these kind of results for doing all kind of intervention strategies. And then that's not the main objective of what we're doing. So we might be much more careful about how these results should be or could be used.
Yeah. Indeed. So, and this is also why we have in the protocol that Grant already referred to, we have dedicated a section on communication and knowledge transfer, because it's indeed very important to be able to explain what the burden estimates mean, how they can be used and how they cannot be used, because they cannot be used for any possible purpose. They can only be used for specific purposes, and essentially to compare the COVID impact compared to the impact of other diseases. Okay. Right. So with that, I would like to ask Professor Jo to take the floor, because we can then go to Korea to have a look at the COVID disease burden in Korea. So Professor Jo, please feel free to share your screen and take the floor. Thank you.
Can you see it? Can you hear me?
Yeah, we can hear you. We see the PowerPoint program, but not the presentation mode or the...
Okay, I will show the... Is it okay?
Yeah, perfect. Thank you.
Okay. Good morning, good afternoon, and good evening. I'm Minu Jo, who is a professor of Department of Preventive Medicine, University of Ulsan College of Medicine. Firstly, thank you for inviting me to this important webinar and your kind introduction. As a member of the Korean National Burden of Disease Study Team, I'm very glad to present our study titled The Burden of Disease Due to COVID-19 in Korea using Disability Adjusted Life Years. The study was published in the Journal of Korean Medical Science last June. If you want to get more information about it, please refer to the article that I shared already in the chatting window. As you know, since the declaration of the pandemic of COVID-19, the pandemic state is still ongoing. According to the WHO website, totally more than 54 million cases of COVID-19 were reported all over the world on 17 November. Until the same day, about 1.3 million people were sacrificed because of COVID-19. In Korea, the first case was identified on 20 January. She was from China. Soon the epidemic occurs. At the time, most cases were believers of a religious group around Daegu and Gyeongbuk area. Around mid-April, new cases had got low. Therefore, the Korean National Burden of Disease Study Team thought that this was the time to estimate burden of disease due to COVID-19 and prepare to turn a later wave. Therefore, we planned this study. It aimed to calculate the burden of disease due to COVID-19 between 20 January and 24 April, so-called first wave in Korea. We adopted the incidence-based approach to calculate the DALY because the approach is familiar with our study team. Our study team have regularly reported the national burden of disease in Korea using this approach. In addition, we could obtain necessary epidemiology data like number of incident case and mortality case on gender and age and disease duration from Korean Center for Disease Prevention and Control. As you may know, one of the important reasons why the Global Burden of Disease Study adopt a new approach, so-called prevalence approach, is that it may be more easier to get prevalence data than incidence data. However, we could get the data. Moreover, prevalent case means active case, but we thought in infectious disease, incidence could show more validly its burden rather than prevalence. So we decided to adopt the incidence-based approach to calculate the burden. You know already two presenters show the concept of DALY. And DALY composed of two components, YLDs and YLL. In order to calculate YLD in the incidence-based approach, it needs a number of confirmed case, disease duration, and disability rate. We got the data of incident case by gender and age group from KCDC. And also we confirmed the data with local government report. It also included foreigners' case. Remember the first case of Korea from China. For disease duration, we calculate it rather than using the government data because they did not provide the latest data, what we need. So we estimated it using data information on confirmed, cured, and disease cases. And symptom experience was also considered. It is different with previous study, but we thought it was more valid. Everyone guesses that I may be infected, and they worry about it, so we considered that. And move to disability rate is a very important issue to discuss. We consider disease severity and mental status due to COVID-19. The health condition varied, so it needs to consider its severity. And because there is no vaccine and treatment of choice, so patient would be very anxious. So we include its mental impact to calculate DALY. So we assume proportion of asymptomatic, mild, moderate, and severe state, considering previous articles and public reporting by KCDC. But because there was no disability rate on COVID-19, so we used disability similar according to expert consultation. For more valid estimate, it needs to estimate its disability rate. To consider disability rate of both COVID-19 state and its mental impact, a multiplicative approach was conducted. And for dealing with this uncertainty of some variables, we did a sensitivity analysis. For YLL, we obtained the data of number of deaths due to COVID-19 by gender and age group from CDC and public media. Finally, using 2018 live table of Korea, we could calculate YLL. Korean population data was from the Statistics Korea Demographic Survey. So I will talk about the result. This slide shows the baseline value of parameter for daily calculation and range of parameters for sensitivity analysis. All number of COVID-19 cases were about 10,700 cases. We assumed 71% of them had mild symptoms. We considered increasement of this proportion to 30%. That was about 92%. Total number of deaths was 240. These values were severity distribution and disability rate and duration of disease. Also, we considered the impact of additional isolation for 2 weeks after discharge in sensitivity analysis. This is the graph showing YLD and YLD per 100,000 people by gender and age group. More pale color means less symptom groups. Those values in 20s in both male and female were highest because they were the main group of the religious group. Okay. YLD of moderate symptom group had the highest proportion. Value of female was higher than that of male in most age groups. This graph shows the result from sensitivity analysis. Disability rate were most important factor. It means that we need a disability rate of COVID-19 for more valid disability adjusted life years. In addition, we could reduce morbid duration. The burden also could decrease according to the sensitivity analysis. Okay. These graphs show YLL and YLL per 100,000 people. In contrast to the YLD result, YLL were higher in old age group than in younger age group. If in the perspective of YLL per population, the value of 18 was highest in both genders. You may know it was due to high case fatality in old age groups. According to the recent report by KCDC, case fatality of 80s was about 20%, but that of 30s was 0.05%. It was 400 times. Therefore, for all age group, primary prevention may be very important. Total DALY due to COVID-19 was about 2,500 by 24 April 2020. about 90% of that was due to YLL. Therefore, in order to manage the burden of COVID-19, mortality should be managed, especially for the old age groups. We compared the result with previous Korean National Burden of Disease study. Fortunately, it has small proportion of the total national burden of disease, but keep in mind, it is ongoing. It was just from first wave. Already, although Korean people are trying to control these epidemic stages, during study time to today, those are increased 3 times and 2 times in incidence and in mortality, respectively. Therefore, total burden might increase more than 2 times. So prevention is most important. Use mask and keep your hygiene. Korea government made a law to people to use masks in public areas. So this is conclusions. This study is the first study to characterize the burden of disease due to COVID-19 in Korea using DALYS. This method also can be applied to other countries where disease notification data are collected by government or other institute. And finally, to control the burden of COVID-19, decision makers should focus on reducing case fatality for preparing the second or later wave of COVID-19. Your attention.
Okay, and thank you, Professor Joe, for this very insightful presentation, and congratulations on the work that you've done on COVID and on the burden of many other diseases in Korea. Since we've run a bit out of time, I suggest that if there would be any questions for Professor Joe, we would be happy to put them by email. But maybe I want to conclude with some take-home messages. So in terms of COVID disease burden, I think we've seen from the examples that it can indeed have a major impact compared to other diseases, and that especially the mortality component is very important. So having good and detailed estimates of the number of deaths on the ages of deaths will be very crucial to have as precise estimates as possible of the COVID disease burden. There are also some uncertainties remaining regarding the impact of long COVID, of the complications that might occur after infection, which could also contribute significantly to the YLD component. And when thinking about the methodology, we've seen that when quantifying COVID burden, as for any other disease, we need to make a lot of assumptions and decisions, and several of these will be very country specific. We need to understand the data that we have within our country and how we can make best use of these data to estimate our DALYS. But some of the assumptions and decisions will also be more generic. Think about the discussions regarding comorbidities, regarding which life expectancy to use. So these are discussions that are not country specific, but can be addressed at an international level. And so in that respect, it's very good to know that with our cost action, with our European Burden of Disease Network, we are able to offer a platform where we can have such kind of discussions and share the thoughts and experiences that we have on this topic. We will not always be able to have a final answer on which assumption or decision is correct. Sometimes there is no correct answer. So what is key is to be as transparent as possible in the documentation of your approach. And also, as we've seen in the examples, to work with scenario or sensitivity analysis in order to quantify and show the potential impact of these choices. So all of this will be very crucial to help us come up with reliable and trustworthy estimates of the burden of COVID. And of course, the same goes for any other disease. So with that, I want to thank you all very much for being here. We were more than 100 people attending this webinar, so that's a very, very satisfying outcome. We will make the presentations and the recordings available through our website, and we will keep you in touch about the further webinars that we will be organizing with our European Burden of Disease Network. A special thanks to our speakers, Professor Joe, Giske, Grant. Thanks to Jose and Sarah for helping us, and thanks to all for being here. And I look forward to seeing you again later on. So have a nice day and a nice weekend, and stay safe. Thank you.
Thank you very much for organizing. Bye-bye.
Thanks.
Thank you. Bye.